Well, thank you. I really don't have much to add after the last two lectures, so I'll make it very brief. And everybody's hungry, so I know you're going to go to dinner. But I want to spend just a few minutes. I'm not going to repeat any of what we spent because that was an excellent review of the literature. We wrote this paper, Tom Hostetter and I, 20 years ago, about diabetic nephropathy. And I can tell you the theme of this paper was that hypertension is bad in diabetes, hyperfiltration is bad, and glycemic control is good. So what I thought I'd do is focus on these three mechanisms and see how much we actually know now compared to 1995 or 1997. But I want to share with you facts that I think are really interesting or evolving. Diabetic kidney disease does develop in 30% of type 1 and 40% of type 2, and this is a major change. We used to teach people it's half of type 1 diabetics and 10% of type 2, and you could see the difference. And most of the excess risk of mortality in diabetes actually does not come from cardiovascular disease. It comes from diabetic kidney disease, which people don't realize. So why do people develop diabetic nephropathy? Only 1 out of 3. Well, there's susceptibility factors, there's initiation factors, and there's progression factors. And certainly older age, men, certain ethnicities are more likely to get diabetic kidney disease, but people with family history of kidney disease are also more likely to develop kidney disease. You could look at this list, and this list was the same list 30 years ago, and it's still the same list today. Really hasn't changed much in terms of what we know about diabetic kidney disease. And this is the classic model that you develop the hyperglycemia, then you have the cellular injury, then you manifest the microalbuminuria, the macroalbuminuria, then kidney function decline. But this slide is really important, and I'll tell you why in a minute. And these are the classic changes that you will see. I think one important thing, changes in type 2 and type 1 are actually not the same. So when we've done serial biopsies on type 2, what you find that in type 2 diabetics, the changes are less reliable and predictable, and 10% or Dr. Megdi said almost 30% of people may have other etiologies other than diabetic kidney disease, which you don't see in type 1. I find this really interesting that I know I've trained in a lot of places, and none of the pathologists use this international classification of glomerular diabetic kidney disease. Everybody, when you send a transplant biopsy, gives you the Banff classification, other classification, but I don't know why this has not caught on where somebody tells you it's diabetic kidney disease stage 3 or 2B. So I don't know who's using this, despite the fact that all pathologists have agreed on this. So let me just show you major features, and these are numbers I remember because it's helpful to teach fellows about diabetic nephropathy. Type 1 diabetes, albuminuria developed 1 to 13 years from onset. 19% of them will have EGFR less than 60 at presentation. Now, the classic teaching was, if you developed albuminuria in type 1, that you will be destined to develop kidney disease. This is no longer true. You could develop transient albuminuria, and it actually does not lead to kidney function. Absence of albuminuria does not mean normal histology. And I think this is really important. So you could have a biopsy-proven diabetic nephropathy by all pathological criteria, and you have no proteinuria whatsoever. 25% of people with diabetic kidney disease will not have proteinuria, which is a major departure of what we have learned. I think in type 2, the numbers are easier to remember. 2% of people go from micro to macroalbuminuria every year. 2% go from 2% from normal to micro, 2% from micro to macro every 2 years. And by 15 years, 15% will have albuminuria. Now, the bottom one is, I think, so important. 40% of type 2 diabetic kidney disease will never develop proteinuria. And it's not understood why, but I think probably what's happening now, ACE inhibitors and ARBs are so commonly used for hypertension that people are taking these drugs for 5-10 years before the diabetes starts. So by the time you see them, they have no proteinuria. So the absence of proteinuria is no longer a reason not to suspect diabetic kidney disease. I think these are two important features of diabetic kidney disease. If you take a diabetic with a GFR of 30 compared to polycystic kidney disease, GFR of 30 or IgA nephropathy, diabetic kidney disease patients are twice more likely to be anemic for the same level of kidney function. More importantly, they are known to exhibit more adynamic bone disease. So these are not the people we want to be very aggressive targeting their parathyroid because of adynamic bone disease. Why are the presentation different between type 1 and type 2? In type 1, you know exactly when the onset is. In type 2, you never know because most people do not have symptoms. They're older, they have more atherosclerosis, and I think type 2 now is behaving different because most people are treated with ACE or ARBs. So Dr. Megdi tried to convince you that hyperglycemia is actually something that slows the progression of kidney disease, and I think there's absolutely no evidence that hyperglycemia helps in diabetic kidney disease. What it helps with, it actually helps you prevent you from going from normal albuminuria to microalbuminuria. It prevents you from going to macroalbuminuria, but there has not been a single study that showed if you have reduced GFR, there has never been a study that randomized patients with reduced GFR to 2 levels of glycemic control to show that glycemic control is better for them. So I think that the glycemic control, I think, is more important for the eyes and early stages of proteinuria, but it's never been shown that it reduces GFR progression, and he talked about the legacy and the metabolic memory, which has been shown to be true in type 1, but that was not a randomized trial. That was a post hoc analysis. So I like glycemic control, but it's never been studied formally too. In type 2, we know that in the United Kingdom prospective study that hemoglobin A1C reduced diabetic kidney disease by 24%, but that only refers to proteinuria, not to slowing progression of kidney disease. Also, Dr. Megdi suggested that KDIGO wants you to have a blood pressure of 120 or 130. I don't know where KDIGO came up with this number. So this is, I think, knowledge should come from randomized trials. I'm sorry, this is the glycemic control, which I just want to show you that the Accord trial achieved a lower glucose control, and as you know, glycemic control was actually not beneficial. So A1C of 7 versus 8 actually was not better for you. So this idea that glycemic control, the lower the better, I don't think it's entirely accurate. So this is the, but again, I think glycemia is very important in preventing early proteinuria, but it's not important later on. I want to show you, this is a paper we published in the New England Journal of Medicine over 15 years ago, and these are type 1 diabetic patients who received a pancreas transplant to treat their diabetes. And you can see on the left panel there was quite a bit of mesangial expansion. The middle slide is after 5 years of being normal glycemic, and the last panel is 10 years. And what you could see is that the mesangial sclerosis actually disappeared with adequate glycemic control. To my knowledge, this is the only paper that ever shown that you could regress the histology of diabetic kidney disease with normal glycemia, but the numbers are small, and certainly it'll be nice to reduplicate these results. Hypertension we just talked about, but this is what we know from Untitled and Accord. These are type 2 diabetics randomized to 120 versus 140, and the question is, does it save lives to have your blood pressure at 120? And the answer is no. So it's very clear in diabetics, type 2 diabetics, that the target blood pressure that is associated with no excess mortality is 140, and the glycemic level is 8 rather than 7. And I think the American guidelines are very clear now that the target blood pressure in diabetics is 140. It's not 120. If you're non-diabetic, it's 120. If you're diabetic, it's 140. Are you listening, Magdi? It's 140.
Yes,
okay,
yes,
all right.
we'll
All right. But they did have less stroke. I don't have much time. I just want to kind of move to the hyperfiltration issue. And this is, this paper now, I think it's very close to 35 years old now or so. When Tom Hoster was a fellow in Brenner's lab, and I happened to train in Tom Hoster's lab. So I grew up with this hyperfiltration. Everything we did in the lab was about hyperfiltration. So let me just, and people use hyperfiltration, kind of the classic model is diabetes. And it's claimed to happen in 75% of type 1 diabetics. Maybe up to 40% of type 2 will have hyperfiltration. And people have a lot of mechanisms. Some people think it's a glomerular hemodynamic. Some people think it's a function of the sodium delivery. But people do believe this happens, and it does happen, certainly more in type 1 than in type 2. And this is the foundation for the trials that has been shown. ACE inhibitors, ARBs, work better in diabetic kidney disease because they reduce this hyperfiltration, and A2 blockade, this is the Renal trial. But let me show you, and I think another study was showing actually how people are even questioning the mechanism of hyperfiltration in type 1. This is looking at the diabetes DCCT trial, and it asked a simple question. If you had a GFR more than 140 mLs per minute hyperfiltration versus less than 140, are you less likely to develop kidney disease? And you could see absolutely no difference. Hyperfiltration, people who had a GFR of 180 had the same risk of kidney disease as GFR of 90. So I think this hyperfiltration story needs to be revisited. I'm sure it exists, but it's not as big of a deal as, look at this slide. This just shows you the hazard of developing kidney failure at levels of GFR, and you could see where when your GFR is 180 and 160, you almost have no risk of kidney disease. But when your GFR gets down to the 80s and 100, that's when your kidney disease goes up. So I think it certainly challenges this hyperfiltration, and I think we need to think about it. This is the same study showing if your GFR is less than 140 versus 140, your risk of getting to GFR less than 60 was similar at 12.8% and 11%. I think this is the hyperfiltration issue. If you remember, people tell you, especially for trainees, if you go on an ACE inhibitor, it's a good thing for you if your creatinine goes up, because that means you'll reduce your hyperfiltration and your kidney function will last you longer. I'm just going to show you 3 papers, and Dr. Megdi showed one of these. This is looking at people in different groups with hypertension. What happens to your creatinine when you go on an ACE inhibitor? Again, remember, we have been taught that if your creatinine goes up by 30% from baseline, it's good for you because it reduces hyperfiltration. And the short story is, people who had a rise in their creatinine after ACE inhibition were actually more likely to die and develop end-stage kidney disease much faster than people who didn't. This is from Elaine Coe, who's really been doing a lot of this at UCSF. Again, patients with, this is from the MDRD and the ASK study. This is another paper, again, showing acute rises in creatinine actually are really bad for you. And I think we've been told it was good, but I don't think it's good. This just shows you the data on the left. If you have less than 5% change in your GFR, 5 to 15, and more than 15%, it gives you the risk. So if your if your creatinine is 1 and you put someone on an ACE inhibitor, their creatinine went up to 1.15, you never worried about it. Well, that person is 7 times more likely to develop end-stage kidney disease in 5 years compared to someone whose creatinine hasn't changed. So I think this is really important as we think about how to treat these patients. So please read this. This is 2 pages. It will kind of help you think about this hyperfiltration issue. Dr. Megdi also said KDIGO likes to recommend salt restriction. I don't know where that comes from. Let me show you this paper from Diabetes Care. This is the largest study ever done on type 2 diabetics with follow-up of 9.9 years, asking what salt intake does to mortality. And the short answer, people in the lowest quartile of sodium intake were more likely to die. And if I show you the details of it, look at for every increase of 100 millimoles of sodium a day, you were 28% less likely to die from cardiovascular disease. So salt restriction in diabetic I think is a very dangerous thing. Again, I'm not saying people should eat all the salt they want, but I think restricting them I think is problematic. And this has been covered, so I'm not going to do this. I think, we focused on the hemodynamic stuff. This is a terrific paper from Carl Trixton's group, just came out in JASN, where they took type 1 diabetic siblings and normal controls, and actually with whole genome sequencing, you could actually identify variants now that are associated with diabetic kidney disease. So I think this is really important, and hopefully we'll see more of this. So I think in conclusion, I think glycemic control is important early on, but it doesn't help once your kidney disease is established. I think level of blood pressure control is still a problem, but I think the evidence points that 140 is safer for diabetics than 120. I think ACEs and ARBs and certainly SGL2 are important now. Acute decline in GFR, and hopefully you will take this point home. People who have a worsening in their creatinine after ACEs and ARBs, this is not a trivial issue. It actually leads or is associated with higher risk of death and end-stage renal disease. Hyperfiltration is perhaps not as important, and salt restriction may be harmful. And this is the first time I finish on time.
Dear doctor, your time.
Thank you very much, Professor Ibrahim. And if you can join us in the podium, actually this session was very enthusiastic, more than expected, because you will leave with a message. Me personally will change my practice. Apart from the metformin, which we shall leave it till the end, I want to solve the debate between Professor Ibrahim and Professor Sharawi. And Professor Ibrahim mentioned 4 points, which is against what Professor Sharawi mentioned. The first is that the glycemic control may decrease the proteinuria micro and macro, but not affecting the progression and GFR. The second is the blood pressure you target for your diabetic is not 130, as Professor Sharawi mentioned. He wants it 140. The third is salt has no evidence to support the delay progression. And the fourth thing is the hyperfiltration. The people with starting 180, 190, this does not mean that they will progress more than if they didn't pass with this hyperfiltration. So if I correct, we have 4 points for a debate, and I will give Professor Magdi only 2 minutes and by stopwatch, and he can choose whatever he wants from these 4, but after 2 minutes he will stop, and Professor Ibrahim will have another 2 points, then we end this, whatever the message is, because we need to ask Professor Debrew about his metformin, because this definitely will change our clinical practice this session if we got to conclusion. So, أيوة حاضر يا بيه، أنا chair person، أنا آخد 10 دقايق يا باشا.
First of all, regarding glycemic control, I think the first study that showed very good effect of glycemic control was started in 1977, the UKPDS, which was published 20 years later in 1997. and then published again in 2007. And 2 years ago, I was in the ESD, the European Society of Diabetes, and again, after 40 years, patients who have well-controlled blood sugar have better preservation of kidney disease. This is the AQPDS, which is, I think, is the most important landmark study in diabetes. Again, it was repercussed in DCCT, which was published in 1994 in type 1 diabetes. And I think most diabetologists will agree that blood sugar control is mandatory, even if the effects are not that clear. Why? Because usually in diabetic patients we start late to preserve the kidney function. It is not the glycemic control, but it is the patient condition. This is the first factor. Dr. Kamal agreed with me. Yes, and I think the legacy effect was debated in another study, but this study also was criticized. They didn't find any legacy, but it was criticized later on. The second point is hypertension.
Blood pressure level.
Blood pressure, this is what Kidigo said this year, 2020, to get blood pressure good, and we have to discuss with them. If you don't like my opinion, we can discuss with them. And also it was repercussed by the ADA guideline and by American Society of Cardiology. Just last December, they stated less than 130, but not less than 120.